My name is Homer Tien, and I'm a general surgeon and trauma surgeon here at Sunnybrook Health Sciences Centre. I spent 25 years with the Canadian Armed Forces as a general practice medical officer and then as a general surgeon, and deployed multiple times to Bosnia, Croatia, and Afghanistan during the war. I'm now the Chief Medical Officer at Orange Air Ambulance, and we spend a fair bit of our time delivering emergency health care to remote First Nations communities in Northern Ontario. And I have an interest in thinking about access to emergency health services in these remote communities. I think right now, because I'm still with the military as in a reserve capacity, I still think about and train, military members here at Sunnybrook in preparation for deployment overseas, and both, to serve our soldiers, but also in a humanitarian relief capacity. As to my work with the air ambulance, it mostly pertains to remote First Nations communities here in Ontario. For the air ambulance Indigenous care, actually we're just starting. We developed a relationship with U of T and different universities in Ontario at the air ambulance, and we're setting up health equity electives and a fellowship in health equity and remote Indigenous care. And what this would look like is that people would work at some of the regional hospitals to do some core rotations at Sioux Lookout or Moose Factory, Waha, but also fly into the remote communities to deliver care and think about how to improve care systematically to these communities. We're also thinking about injury prevention strategies and courses for some of these areas as well. So we did a Stop the Bleeding course with Dr. Nathans and Sunnybrook up in Moose Factory. Sunnybrook has something called the PARTY program, Prevent Alcohol-Related Trauma in Youth, and we've delivered some of these on reserves in Northern Ontario. Absolutely. We would love, acute care, delivery of acute care is a major problem in these areas. And certainly surgical residents have an amazing ability to resuscitate, to assess and treat injured and sick patients. So we would certainly welcome them as part of any elective program that we offer. We're starting to experiment with that. We do telemedicine, so we provide telemedicine advice to the nurses in these nursing stations. We do delivery of point-of-care lab tests, so we're trying to prevent unnecessary transports if possible. And our aircraft will go out and provide care as they bring them to some of the regional centers. And so the presence of our residents on some of these aircraft would be welcome if they were interested. I think the problems are actually very common in some of these remote communities. There's actually a lack of primary health care. There's a lack of obviously specialized health care. There's a lack of diagnostic imaging, lab tests, lack of clean water. And most of these communities are air accessible only. So you can imagine in the winter or when there's freezing rain or bad inclement weather, they're actually quite isolated. And it's a challenge delivering care to these communities.
Right.
Actually, going up north is probably more like the humanitarian surgery work that most of my colleagues at the University of Toronto who do NGO work are familiar with. Fewer resources, fewer diagnostic imaging modalities. Certainly, there's very little in terms of advanced diagnostics and even advanced capabilities in the north. You know, I think if we're not talking about something radical like building a tertiary care center in each one of these remote communities of 2,000 or 3,000, which is I think is highly unlikely. I think it's about innovative use of technology. So things like telemedicine, um, you know, point of care lab testing, and telementoring, but then also better education for the motivated healthcare providers in the area. So you have a lot of very skilled nurses who work in these communities, but you know, they're not necessarily trained to resuscitate or do some of these resuscitative procedures. And I think if we were able to train them better, we can certainly improve care in those areas. Absolutely. I think, you know, we all enjoy the responsibility and the technical challenges of surgery and, you know, operating on a patient and seeing him or her get better. But this is sort of a system improvement. And I think we have, at least for in emergency healthcare, we have a great resource in terms of, we are a great resource in terms of, you know, being able to provide definitive hemorrhage control, sepsis control, or revascularization of limbs or the torso organs. And so we're a resource that can help improve the system for some of these communities. And I think it's a way of improving the healthcare a community at a time instead of an individual at a time.